Good evening, everyone. So I'll be talking about troubleshooting and complication during angioplasty of the fistula. So this is actually a talk which is prepared by me uh, uh, sometime back for a workshop in Kaveri Hospital at Bangalore. So I'm just sharing the same things. So here I'll be talking about how to troubleshoot different things which we face right from deciding the axis as to what to take and until the we reach the hemodynamic or anatomic outcomes. So first, fundamental to any AVF interventions, and one more thing, I'll not be covering about central vein complications here. I'll be sticking myself only to the fistula vein and the anastomosis and the artery, and not going to the central
Fine,
veins.
fine.
Fundamentals of any AVF fistula interventions are the access as to how to take the access and negotiating the wire. The next thing and delivering the device, that is a balloon on the side of stenosis, and then looking at the hemodynamic or the anatomical outcomes. So first thing that we should understand is to how to troubleshoot an access approach. So first we should decide as to what we are treating. So a thorough ultrasound examination is needed. Pre-procedure, starting from the anastomosis, the juxtaanastomotic segment, the body of the AVF and the outflow vein being traced up to the subclavian vein. So we can see it nicely in the ultrasound. And that defines its anatomy, its internal diameter and the wall thickness. And the color Doppler will show the aliasing phenomena at the site of the lesion. And even otherwise, clinically, when we do an examination of the fistula, we can very nicely understand where is the site of the stenosis and even explain to the patient, even otherwise, as to what is the problem in the fistula. So spectrodoppler will confirm the site of the lesion by increasing the peak systolic velocity. And after we decide what is the location where we need to treat the lesion is there, then we have to decide what axis we are taking. So it can be antegrade or retrograde, and the axis can be arterial or venous. So the introducer sheet should be directed towards the lesion, and it should be sufficient length from the entry point of the sheet into the vein or artery and the suspect lesion so as to accommodate the length of the balloon and some length for the sheath. So at least 1 centimeter of the sheath should be inside the vein or the artery, and at least 1 to 2 centimeters of the balloon should be there. So approximately from the suspected site, this entry point into the vein should be at least 2 to 3 centimeters to accommodate the balloon as well as the sheath. So this is what I usually practice so that we can decide what to where to take an axis. And second thing, what I usually think is to take a single axis so as to reduce the time in which we are doing the procedure, because we share cath lab with many other people, and we also have other procedures to do at a similar time, maybe another plasty or creating a fistula or something. So I prefer to quickly finish the procedure without taking multiple sheets or multiple accesses whenever it is possible. Sometimes it will not be possible to take a single access. So this one image I put here, this fistula was done by me, an RC fistula. And another thing that I follow is that I don't make a distal fistula at the wrist or at the umbilical stuff box, because I feel that I need to keep a space for me at least 2 to 3 centimeters at the wrist joint to have a sheath at a later place whenever it is needed. May not everyone will need that, but then yeah, of course we reduce. Maybe we are losing one site at proximalizing it, but then if you do slightly above the wrist, it is much easier for you to take an arterial access. Maybe Shaba sir might not be accepting with this arterial access, but still arterial access reduces the time in which you're doing the procedure, as well as it. I have not seen much of complications like the radial artery rupture or radial artery occlusion. So going by this axis has two lesions here. There is one lesion at the just a minute. There is one lesion slightly above the juxtaanastomotic segment here, and there is another lesion here at the elbow, where we see where it is joining the basilic vein. So there is no cephalic vein outflow here. There is only the basilic vein outflow beyond the arm. So once we have taken an angiogram, we should also see, we should understand which is the artery, which is the vein, what are all these structures which you see. We see a lot of collaterals here, and we should be able to identify that this is the anastomosis, this is the proximal artery, this is the distal artery where my sheath is there, and this is the outflow vein, and then there is a lesion here. Because sometimes with multiple collaterals there, because of stenosis, the picture might get confused. So this is an antegrade axis taken through the radial artery. By taking this axis, we can tackle both the outflow and the inflow lesion here. So, axis approach in RC-AVF, in case of a junctional stenosis or stenosis in the body of AVF, you consider either retrograde transvenous axis or a transradial axis. And in case of an outflow stenosis of the cephalic vein at elbow or the arm, consider an antegrade transvenous axis. So, always no need to go to the artery. If you have a space to take an antegrade axis in the vein, just above the anastomosis or in the junctional spondylic area where you need to treat an outflow lesion, you can cannulate the vein as well. But slightly, I prefer to take a less of an retrograde approach as compared to an antegrade approach. So this is a thing where we have taken an antegrade approach to the transradial to treat this junctional spondylic stenosis. Here there is a single lesion. We can see the artery and the vein and the anastomosis and see these are the arterial branches which are there. So this is a retrograde transvenous approach to treat again the same junctional spondylic stenosis. Here the artery was not good. So in this case, what we did was after treating this particular lesion, there was also probably one anastomotic stenosis here. So next we took a guide wire. Once we have crossed the guide wire into the proximal artery and then inflated this area as a C, then what I usually prefer is that the distal artery has got stenosed here because of my own surgical problem. Because when usually in females, this was a female, and usually in females, artery might the radial artery might be quite small before creating fistula, and then inadvertently because of some bleeding after creating fistula or something, when you're taking another suture, the distal artery might have got stenosed. So in this case, we couldn't take a transradial approach here. That's why we had to take this one approach from the retrograde vein. So after doing the plasty of this particular lesion at the junctional spondylic and the anastomotic area, so what I do is that I try to take the wire into the distal artery and then inflate a 3 mm or a 4 mm balloon here across, because the lesion is there here, not anywhere in the distal artery below. So once you inflated this part, the distal artery now becomes very good. So this helps in two things. One, it increases the flow to the fistula from the ulnar side. And another thing is that it gives an additional access for you next time. If at all you need to, this region recoils or something, it gives another access for you where you can go from the artery. So about the point about the retrograde approach is that we need to actually cross the wire across the lesion to actually visualize the lesion. Otherwise, we may have to take a reflex angiogram. Sometimes reflex angiogram, your hand may shake while they're taking it or something. So you may not exactly know where the lesion is when you want to cross the wire. Especially in very narrow lesions, where otherwise the ultrasound may help it to cross the lesion, but otherwise radiographically you may not be able to see it so well. And again, every time to take an angiogram after inflating a balloon, you need to put a catheter around, take the wire out, then give an angiogram and put the wire back and then remove the catheter. So multiple steps should be done to see an angiogram after this approach. So antegrade approach scores over this because antegrade approach directly we can take an angiogram and no need to put a catheter or something. So usually in my procedures I don't take a catheter at all, because usually I feel the wire will cross by itself, except in some places where there is extremely narrow, just to give a support to the wire. Otherwise usually I don't use a catheter to cross the lesion. So a thorough ultrasound examination is needed to have a knowledge as to what lesions are there. It's not be a surprise for you. Of course, central vein can be a surprise because sometimes in malfunctional fistula, central vein lesion may not be symptomatic. But otherwise, usually all the fistula lesions we should be aware of before before going to the procedure table. So this is where a fistula has been made at the very distalmost site at the wrist, and then we take a approach to the radial artery cannulation at the anatomical stuff box. So this is what I said. I give a small space for me here, so that I usually give an incision here and join the artery and vein. So I give a small space here so that I can use it for cannulating the radial artery. So if at all some JS develops or the fistula gets stenosed or thrombosed and you need to proximalize, you can still proximalize it here, and then of course you can proximalize it here. So essentially I may be losing one site. If I do it here, I may be able to do another one here, but then yeah, I think that gives a little bit of edge over it. And access approach in BCF. So in BC fistulas, you don't prefer to take a transradial approach unless and until there is a very long segment stenosis in the whole of the vein, and other than taking a femoral vein approach, which becomes slightly difficult in such a long stenosis, I take a transradial approach in that case. Otherwise, I usually take a retrograde approach in the brachiocephalic AV fistula to treat stenosis in the juxtational stenotic area on the body of AVF. And in case of course, outflow stenosis, as in the previous case discussed by Dr. Deepak, where we take an antegrade transvenous approach to treat outflow lesion. So this is a similar picture where you've taken antegrade transvenous approach to treat a lesion here that is in the somewhere in the body of the fistula in the midarm. So this is a reticular approach taken to treat juxtational stenosis in a brachiocephalic fistula. So another approach which you can think about is this vein which is there. This is called the axially-cephalic vein or the lateral cephalic vein. So this person had a stenosis here that is in the midarm. This is a brachiocephalic fistula. My sheath is there in this outflow cephalic vein in the fistula. When you take an angiogram, we can see that the blood flow is actually going through this axially-cephalic vein here, going down, further continuing down in the forearm, going like this into the forearm, and then finally reaching here, and then connecting to the cephalic vein in the forearm. So this green, this vein which I have marked in the green line is the cephalic vein in the forearm, and then finally that connects through the basilic vein in the arm. There is a red line. This is the basilic vein in the arm, finally going to the central veins. So this vein can actually be used as an access, because this is not a vein which is there as a outflow vein of fistula. But this vein is quite superficial, and sometimes because of high pressure inside this vein, the vein can have some hematomas or something when you try to cannulate this. But yeah, I do prefer to take these veins if there is no lesion in this segment of the cephalic vein. So because otherwise, if there is any stenosis in this segment of the cephalic vein where before this axially cephalic vein joins cephalic vein, then you may need to cannulate the cephalic vein in the outflow itself just after the juxtational stenotic area. So this is the same vein which has been cannulated here. So this is the blue mark where my sheath is there. So here again the lesion is same thing. This is the outflow vein of the fistula, and then anastomosis is there somewhere here. This is the juxtational stenotic segment, and somewhere anastomosis is there somewhere in this area. And this is how we take access to this. This is a lateral cephalic vein or the axial cephalic vein, and then we treat the lesion like this because there was no lesion in this area as such on ultrasound. So this is another case where we saw a very long segment stenosis here. So we see that there is no space. Actually, this segment looks good, but it's actually not good in ultrasound. There is a clot here. This is the arterial segment which they are cannulating, and this is the venous segment which they are cannulating. And we see that there is a stenosis here also. So in this case, we actually don't have a vein to cannulate a retrograde area. Otherwise, I have to cannulate somewhere here, which is extremely difficult to cannulate at this point to put a sheet to tackle all this lesion here. So here in this case, I have taken a transradial approach here. So I can see my sheath is there in the radial artery below, and this is the brachial artery, and then we can see this segment. The juxtational stenotic segment looks okay, but there is a clot here in the a partial clot in the arterial cannulation segment. This is actually quite aneurysmal. It's not seen here because the thrombus is not being opacified. The thrombus is there here somewhere in this area. And we should always be ready for surprises. Like in this case, this is a malfunctional fistula, and then we can see that there is a complete occlusion here in this. Or probably it's not a complete occlusion because my wire could cross from here. But since it was a malfunctional fistula, this was not creating any symptoms. So these are the different access approaches that you should be aware of before starting the procedure. Next is troubleshooting the access cannulation. So this is how we cannulate the radial artery. So this is the long axis in plane view, and this is the short axis outer plane view. So I prefer this short axis out of plane view because it's quite a little difficult to do it in plane view, because sometimes the probe, if you have a hockey stick probe or something, it's quite easier. But if the normal probe, it becomes a little clumsy, and then even the magnification with the hockey stick probe is much more as compared to that of the normal probe, normal linear probe. That's why it becomes a little difficult to do it with this approach. But what I prefer is this short axis out of plane view. So this is how a radial artery is cannulated conventionally by just feeling and palpating and going at 30 degrees and then going through and then taking it back. But what we we should be learning to do is to do this in the dynamic needle tip positioning technique, where we put the probe here, and then we put the needle here. Then as we see this, we see the needle tip here somewhere, and then we take the probe front. Now we don't see the needle tip. Needle tip is the most brightest point that we can see in the needle because of the bevel. It reflects multiple ultrasonic waves, and the needle shaft will not be as bright as the needle tip. This is what we should see when we even cannulate the internal jugular vein for putting jugular catheters or the tunnel catheters. So then we advance it so that we see the needle tip again indenting the wall here, and then further advance it so that we see the needle tip inside. Next, what we do is we push the probe ahead again, and then we don't see anything, and then I adjust the needle so that we reach again the center of this. So we should not be in a hurry to. Usually, what happens with cath lab technicians, they are the cardiologists usually don't cannulate the radial artery. They make the technician to cannulate, and they only after it is cannulated they take over it. So usually the technicians who are there with us, they are more doing cardiology procedures, and even with vascular surgeons who prefer to cannulate the artery as compared to the vein. So in these settings, they usually tell, oh, blood has come, and then you can take the sheath out, because many people they use these introducer needles, that is 20 gauge or 21 gauge introducer needles without the sleeve, but I prefer using these IV cannulas or the introducer that comes with the Terimo sheath, which has an outer sleeve and inner needle. So first the needle will, as the needle enters inside, the sheath would not have entered the vein or the artery, and then you will see a flash of blood coming in that needle. You should not be in a hurry to take it out. You should be comfortably you should be comfortably positioned inside the vein, and the whole of the sleeve, you should be sure that the sleeve has also entered inside the vein or the artery which you want to cannulate, and then only you should take the stillet out. And not be in a hurry that you remove the stillet or that metallic stillet out even before the sheath has entered inside the plastic sleeve has entered inside the vein. Then you may lose the access, and there can be a dissection or a mild hematoma happening there because you have already punctured the vessel. Next, troubleshooting is the sheath preference. So most of our balloons that we use in a fistula are up to 7 mm. So 7 mm balloons, they need a 6 French sheath to account them at least. So better to take a 6 French sheath. Even though new unused low entry profile balloons like the Mustang or the Armada, they do can be sent in a 5 French sheath. And you should be sure about what specification is written on the carton of the balloon. And so it's written here 5 French in bold letters that this balloon is only a 5 French sheath and not a 4 French sheath. So usually 4 French sheath is only taken for taking angiograms. And I personally believe that the angiograms have no role, or a fistulogram has no role when we have a good ultrasound with us, where we can understand that there is where is the height of lesion and what is the lesion, and of course measure the flow across the fistulas. So in case you need to insert a higher size balloon, like usually for a cephalic arch or some very aneurysmal fistulas, you may need to take an 8 mm balloon or something like that. In that case, a 6 French sheath may be inadequate. So in that case, you can use this slender sheath, Terimo sheath, where the inner diameter is the wall thickness is quite thin, and the inner diameter of this sheath is similar to a 6 French sheath. So this green colored sheath is 6 French sheath. So this is a 6 French slender sheath where the inner diameter is similar to that of a 6 French conventional sheath, whereas the outer diameter of the slender sheath is same like that of a 5 French. So the gray colored sheaths are 5 French sheaths. So the outer diameter is similar to that of an outer diameter of a 5 French conventional sheath. But be careful, these slender sheaths are very thin, and when you're taking out the balloon or putting the balloon inside, they can just get kinked. And sometimes when you're unaware, and the sheath might slightly try to come outside, and then we may not be able to push the sheath inside, and it will get kinked at the point where it's entering the skin. Whereas the other sheath can slightly go inside. Like if you feel the sheath is coming out and you want to push the sheath inside, the cylinder sheath might not go inside because the tightness provided by the skin itself is sufficient for the cylinder sheath to get kinked. And other important thing is that once you need to change another thing is that these cylinder sheath come in 10 centimeter lengths. So you should be aware that the large amount of sheath can be still outside the body. And whereas the conventional sheath occurs in, it is available in 7 centimeters length. So the dilators of these sheaths, the Terimo, the slender sheath as well as the radial sheath, they are compatible with only 0.025 inch wires and not the routine 0.035 inch wires. So we need to, when we need to change a sheath, you should be aware that we may not be able to use a Terimo sheath, and we may have to use another femoral sheath. These femoral sheaths are compatible with 0.035 inch wires. Of course, there are other thermo sheets but they may not be commonly available in our cath lab, because usually the 0.035 inch compatible dilator sheets are usually called the femoral sheets, which are 11 centimeters in length. And these are called the radial sheaths, the thermo-radial sheaths, which are 7 centimeter length, and these sheaths are not compatible with the 0.035 inch wires. So the next thing is to troubleshooting navigating the wire. So the guide wire that is commonly used is the Teremo wire. That is, it has a nitinol core with a polyurethane hydrophilic coating, and polyurethane and a hydrophilic coating. And usually, what we use an angled tip wire. We can use a straight tip wire also. And many times we may feel that we are able to we are thinking that we are able to navigate the wire, but the wire is not moving ahead. So it's a very slippery wire. So the secret to hold it is that you should hold it in between the pulp of your index finger and the nail of the thumb. So that's how you are able to rotate the wire and then push the wire also to give an appropriate torque. So the and another thing that you should we should see is that we can use an ultrasound on and off to see where the wire is going. But otherwise, when you are seeing in a fluoroscopy, we need to understand the anatomy as to where we are supposed to rotate the wire. So sometimes you may feel that the wire is going somewhere in a different direction. So we should not push the wire in that direction, because that may injure the vein, and that may cause extravasation and hematoma formation, because already the fistula will have higher flow than normal veins. So we should be having an idea of the anatomy in our own mind when we are looking at the angiography, fluoroscopy, as to where to rotate the wire and how exactly, where is the vein and where is the artery, where is the anastomosis. All these things we should have. Taking help of the ultrasound on and off may become slightly clumsy, because we need to again shift our table out, because many places may have these floor mounted machines, and it's become slightly difficult to keep using the ultrasound on and off without moving the table or the moving the image intensifier, something like that. So we should have an idea in the brain as to where to rotate the wire and where to push it. So we can use smaller size wire like the O18 wires or the O14 wires, which are the PTCA wires. So advantage of these O35 wires are that they give more strength, they give more pushability. Pushability means the shaft of the wire following the tip of the wire, and they give more support to delivering device like the balloons and the catheters, and they have more torqueability. Whereas the smaller wires, that is the narrower wires, as the O14 and O18, they are more flexible, and they can be used to navigate very tighter lesions, and they are more trackable. Trackability means that they are able to cross the tortuous vessel more as compared to that of the larger wires. So we can use a torque device also, can be of great help to give quick rotational movements. So next, troubleshooting the exact wire length. So two things we should consider: that is the distance of the lesion from the sheath and the length of the balloon catheter available in the inventory. So usually the IR people, they prefer the transfemoral approach or something like that. So usually in the cath lab in Manipal, all the balloons are 150 centimeter length. So I cannot take a, I mean 135 centimeter length balloons are there. So I cannot take a 150 centimeter wire at all. So usually I need to use a 260 centimeter wire also only. So what we need to understand is that most of our lesions, if we are the farthest site of access will be the radial artery, that is the distal radial artery. So even if you're taking the distal radial artery approach to tackle a lesion at cephalic arch, of course it should not be done, but I'm just telling you, if you are able to, I mean, if you are also using that approach to tackle the cephalic arch, even in that case, a normal 150 centimeter wire is sufficient to tackle that. We don't need 260 centimeter wires unless and until we are using a femoral approach to tackle them. So any lesion up to the cephalic arch, the farthest side, that is a radial artery, can be tackled with a 150 centimeter wire. Of course, for the retrograde approach, even smaller wires are sufficient, and 150 centimeter is not required. So two situation where we need longer wires, that is 260 centimeter wire, is that femoral access when it's used, and if a 150 centimeter balloon catheters are only available with us. So in a large case, in most of the cases, if a major part of the wire is outside, it can compromise with the sterility, and sometimes the wire may fall to the floor if the nursing assistant with you is a little not very quick enough. Next, troubleshooting is delivering the balloon. So a balloon is to be delivered, then the wires which are more flexible, they support less to deliver these devices. So sometimes what happens is that when we see lesions where we are able to cross the wire, but we are not able to deliver the balloon. So in that case, what things we can try before we are trying furthermore? So simple things which we can try is that we can ask the assistant to keep the wire outside straight and taut. The balloon and the wire, the balloon catheter and the wire should be straight, and the assistant should not hold the balloon catheter, but he should be holding the wire straight and giving a slightly pulling action, not pulling the catheter wire out. So some assistant, they may not know what you're telling. They may just keep pulling, and the wire may come outside. But it should be kept taut, and as the catheter gets straight, it will get a little bit of strength to cross the lesion. So this is first thing that usually I do before changing the wire or changing, something else. But this usually helps. Second thing that we can do is that if you are still not able to push it across, we can just inflate the balloon there, because that is the tight point where of the stenosis where it is there. So you can just inflate the balloon at the point where the balloon is not further able to go ahead. So probably the tip of the balloon will be there at that lesion, and then slightly the lesion will get inflated. And then that is enough. Actually, what is most important to understand is that the outflow should be treated first and not the inflow. So once you have, but then to push the balloon ahead, at least we have to do something. So slightly we can inflate that part where the stenosis is there and where we are not able to further push the balloon. And then once that is treated, you can go to the furthest most point where the stenosis is there, and then come down from there or come upstream from there. So once this is done, balloons can be further advanced. So both these maneuvers are extremely important in balloon maceration thrombectomy of the thrombus AV fistula, so that you can able to macerate the thrombus. We can other thing, if both these maneuvers fail, what we can use it, we can use a stiff tight thermo wire. This stiff tight thermo has a larger retinol core as compared to standard type wire. So we can see this in this diagram. This is standard wire. This is a half stiff and full stiff. We can see that the polyurethane coating has come down in this, where the coating of the wire has been reduced, whereas the core of the wire, the retinol core of the wire has been increased, so that has to give stiffness. Whereas the tip and the taper of these wires are still flexible enough to help in navigation. Whereas the amplan super stiff wire, they are usually not used to navigate, because they are quite stiff enough and they can cause injury to the vessel and may even cause extravasation of the injury to the vessel and then cause extravasation of the blood. So other thing is that to take these wires, if at all you are taking amplan super stiff wire, you should be able to first put a catheter across the lesion, and then take this existing wire out and then put this new wire. So in that case, we can't use a larger sized balloon, catheters, because our balloon itself, which is a 5 French compatible balloon itself, is not crossing the lesion, means that a 5 French catheter might also not cross the lesion. So we need to keep smaller catheters with us, that is a 4 French size catheter, so that they are able to cross it. So in this, I just wanted to show as to how we tackled the CT of the left brachiocephalic vein, where we couldn't deliver the balloon after crossing the lesion. So this fistula was created by me, and this lady surprisingly did not have any left-sided catheter at all. She only had a right-sided catheter. And then what is important to understand is that this catheter was quite high in the neck. So this was inserted somewhere outside, where they had just below the chin, they had taken an insertion point, and I'm not sure where exactly the catheter tip was placed initially. That was a temporary catheter, and subsequently we created a left-sided brachiocephalic AV fistula. And after creating the fistula, she started developing edema of the left upper limb. And even though the catheter vintage was only 2 months, probably the catheter tip was somewhere indenting the junction of the both the brachiocephalic vein, or probably the catheter tip was directed towards the left brachiocephalic vein. I'm not sure what it was exactly, but then the catheter vintage was only 2 months. And she developed swelling of the left upper limb, and she was taken for venoplasty. So this was the venogram image. So initially we had taken a outflow to the access to the outflow cephalic vein, and we had taken an angiogram which shows that there is a complete occlusion of the left brachiocephalic vein. There is no flow down into the SVC. So we failed to cross this lesion through this cephalic vein sheath, and then I decided that we should be taking a right femoral vein approach. So now through this approach, we could negotiate this 035 wire easily without much difficulty across this lesion into the the further of the brachiocephalic vein and the subclavian vein. So after passing the wire, we could see that we are not able to pass any balloon or the catheter across this lesion over the wire. So now I was in fix as to whether I should take this wire out or directly try take this wire out and directly try with a stiff type thermo wire, because I was afraid that if I'm not able to cross it again, then I may be in a soup. So what we tried was that our technician suggested that why not inflate a coronary balloon across this. So through this existing sheath, we passed a PTCA wire, that is 014 wire, across this, cross the lesion with this wire again. So there were two wires across this. I will show the image. And then we inflated a 4 mm coronary balloon there across the lesion. Now after this, we could deliver the larger balloon. So what happened was that what we did was that we now passed, this is our 035 wire, the dark wire. And then by the side of it, we have passed a 014 coronary balloon here, and we inflated a 4 mm balloon here. So once it is inflated, there was some space for our routine balloon to pass through. So we have taken a 8 mm balloon here and then upsized to a 12 mm balloon, and finally the CTO is opened up. Of course, this lady had a early recurrence of the lesion, and then to do a stenting of this lesion. So next troubleshooting is the extravascular migration of the wire. So while we negotiate very tight or long segment lesions, there is a risk that there may be a rupture of the vein or any false tract can be there in the extravascular tissue, and further manipulation of the wire across it, the wire will go into this false tract only always. And especially if the fistula is already working, then there can be hematoma, and then further the flow in the fistula might get stopped, and there can be thrombosis of the vessel also, because the vein is already very narrow at that point, and then already you have caused hematoma. So in such cases, we should not be afraid of what we are doing. We should be we should be confident enough that we are not. We should be stable enough. We should not panic or something like that, that the fistula has got thrombosed. No, because it has happened a few times to me that the working fistula gets converted into a thrombosed fistula. But we should be stable enough to understand that we can handle this situation. That is the first thing. So we need to wait for some time so that we can give an external tamponade, because we cannot give an internal tamponade because our wire has not crossed the lesion now. So we can give an external tamponade with compression, give some time for the fistula, the hematoma will settle down, and the hematoma will organize, and the vein will again start taking its shape. So this might have quite sometimes happened in the dialysis unit also, where the technician has cannulated the vein and there is a hematoma, and they again try to cannulate, and then the fistula has got thrombosed, something like that. This type of situations we might have faced in the dialysis units also. So in that situation also, we have to take some time. The vein will by itself again start opening up, because the blood wants to go in the normal path rather than going in the abnormal path. So wait for some time, give an external tamponade so that the blood doesn't come out of the already created place in the rent in the vein because of the wire. And don't try to flush saline or large amount of contrast rapidly. This will only worsen the hematoma, because it will get extravasated and collect there. So instead of taking angiogram shoot, try to visualize what is there in the ultrasound. We will most of the times we'll understand what is the problem, and if after that, try to take smaller wires and try to negotiate them. Or we can take a fresh axis. If you're taking antegrade, take a retrograde axis so that we are able to cross the lesion. So this is one case where we try to tackle extravascular migration of the wire. So we see that there is a brachiocephalic fistula which I had created, and she had a dialysis vintage of 1 year with the right IJV TCC, and then we created a ref brachiocephalic AV fistula around 5 months back, and she started developing persistent high venous pressure. Ultrasound revealed that there was some stenosis. I was not clear that the stenosis was so critical, but I was sure that there was an outflow stenosis for some long segment. So we planned her for an angioplasty of the outflow cephalic vein. So we can see that there is a long segment stenosis here again, and there is a stenosis here again, and there is a stenosis here again near the cephalic arch. So there are multiple stenosis at the multiple levels. But of course, the juxtanosmotic segment anastomosis and slightly above, it was fine. So we took an antegrade transvenous approach only, and not cannulating the radial artery or something. We took an approach to the transvenous approach by cannulating somewhere just above the anastomosis. So here we could see that the wire could not pass the stenotic segment, and further I was trying to manipulate the wire, and then I see that the wire has gone outside. I realize it, and then I took an angio image. I see that the fistula has got thrombosed now. But actually, the fistula was not thrombosed because there was this axillary cephalic vein. So thrill was still there, but blood was not going through this particular vein, the main vein where the outflow vein. The blood was flowing through this axillary cephalic vein somewhere down, and of course the thrill was there. That was a breather for me that the thrill had not disappeared. So after this, I tried to take a O18 wire. So here again, I tried to take a O18 wire. We can see this contrast which is given in the previous film, still extravascular and collected here. So that also failed. So we had to take a next approach. I could not cannulate anywhere above because there was a long segment stenosis here again at the cephalic arch or just below that. So we took a transfemoral approach from the right side, and we could see that the wire is now reaching from the this one to from the it has got the cephalic arch and finally reached here at the site where it had extravasated. So now what we did is we realized that the stenosis was so severe that it was not able to navigate from there. By doing all this time, we had taken a lot of time in this. Approximately 15 to 20 minutes had passed through, and now the hematoma got organized properly, and the vein was again started to be visible on this area. So our wire, which we had crossed, we had taken from the femoral area. So this is a O14 wire, the coronary wire, which is there and reached here. And this is my wire, which I'm trying to start navigating from the antegrade cephalic vein sheath. So now I realized that both wires had met at the same place, at which you could confirm in the ultrasound that it is this wire has the lower wire, that is the antegrade wire from the cephalic vein, is not is not gone extravascular, but it is in the vein only. So now I was confident that I could be able to pass the wire across and then inflate a 5 mm balloon and then subsequently a 7 mm balloon. We can see the wasting in both the veins, and then this is how it happens after the procedure, where the vein is quite well dilated. Even the cephalic arch area looks dilated, and this was the vein which had actually maintained the thrill when this vein had got thrombosed. So this vein is quite useful, and even we could have taken access through that vein also. So next troubleshooting is non-effacement of the wasting of balloon. So usually fistula lesions are not like arterial lesions. Because usually where the vascular or the IR people are there, they will be using not ultra high pressure balloons, because what I face is that the athletics balloon by the Boston Scientific or the Conquest or the recently launched the Proxcath by the Scepter. So these are all ultra high pressure balloons. They are not available easily in the inventory there, because the arterial lesions which are for which the PTA done for arterial lesions, usually they are not these high pressure fibrotic lesions, and they can manage with Mustang or Armada balloons. So we need to have these ultra high pressure balloons in our inventory, and these ultra high pressure balloons, they have a slightly higher entry profile, and they need so this is a 6 mm balloon here, and this shows that the catheter we need is introducer sheath we need is the 6 French sheath. And this is not compatible with the 5 French sheaths. So this is a new balloon. New balloon. If we are using an already used or the Oxford balloons, then probably may need a 7 French sheath. And second thing is that these balloons, they have braiding around them, and these balloons are not good for balloon maceration thrombectomy, because I feel they injure the when when we push a half inflated balloon across the vein. I feel that these braidings, they injure the other normal venous segment, and they can cause some injury to the vein, and the normal venous segment can get thrombosed or thrombosed because of balloon maceration, because of these ultra high pressure balloons. So ultra high pressure balloons, I only strictly limited to treat the stenosis, and if at all any thrombus is there for in a thrombus fistula to macerate the thrombus, I usually go to this normal high pressure balloons like the Mustang, because they have a surface on the outside, that is the uh, nylon surface, whereas these have braidings on them on this nylon surface. So that makes I feel that causes injury to the vein when we push the half inflated balloon across, even in the normal areas. So next troubleshooting is rupture of the vein. So rupture of the veins is also seen. It can be uh, quite high in some lesions like the transposed AV fistula. So there can be rupture at the place where the basilic vein has been transposed, and especially if you're using a high pressure balloon there across, or if we are doing maceration across in a thrombosed brachio-basilic fistula which is transposed, and also the incidence of rupture is higher in cephalic arch. If it is severe, it can cause pseudoaneurysm, and management is usually by external tamponade by compression and internal tamponade by balloon inflation at normal pressure for prolonged time. So there is a classification which is subclinical extravasation, grade 1 extravasation, grade 2 extravasation, grade 3 extravasation. The point is that the subclinical extravasation, there is no clinical sign, it's only seen on ultrasound. Whereas grade 1 extravasation is that it is stable and it is not interfere with the flow. And grade 2 extravasation is that the flow is stops or flow stopped or flow slows down, and it is also stable. Whereas grade 3 extravasation is that it is pulsatile and rapidly expands and it requires immediate treatment. So treatment for subclinical extravasation, no treatment is required. For grade 1 extravasation, symptomatic management, even in this again, we don't need to give an internal tamponade with the balloon. Whereas if the flow is stopped or flow slows down, we need to give an internal tamponade with the balloon. And if it is not treated, then we may have to use an endovascular stent, the covered stent, or in grade 3 extravasation, the main treatment is to use an endovascular stent, or to, if that is not possible, to occlude the access or to ligate the access. So this is one case of a cephalic arch stenosis. We see an elderly, middle-aged female with the percent high venous pressure. We were sure that we are treating it as cephalic arch stenosis on the ultrasound. So this was a stenosis, critical stenosis. We inflated a 7 mm balloon, and I see that after inflation, there is an extravasation here. So after doing this, I even realized that this is just an image, but what we should also have an idea is that what is the flow of the contrast that is going through. So we have to have a picture in the mind, like what is the flow across when we take an angiogram, what is the speed of the flow. So what we usually use is a 4 frame per second or 5 frame per second. That speed has to be kept constant in the DSM machine. So you should not change the speed. We should not keep a very low speed or a very high speed, because if we get a very high speed, then the radiation exposure will increase. And if we keep a very low speed, then we may not be able to ideally understand what is the flow in the fistula. So I usually keep a 4 or 5 frame per second speed in the angiography machine, so as to see what is the flow in the fistula. That should be recorded in your brain as to understand what was the speed before and what was speed of the flow after the procedure. So here again, I see that the flow has become sluggish here. This we cannot see in this picture. I have not put the video. So I realized that the flow has come down. So now what we did was that we took a same balloon, that was a 7 mm balloon here across, and then inflated it where there was a stenosis. We can see that the still contrast is stuck here of the previous angio. We can still the contrast not moved and it has stuck there. So the flow in the fistula has come down. So after this giving internal tamponade, we see that the flow is again re-established, and then there is no more extravasation. So in case where we are not able to treat it with this, we can use covered stent or stent graft. So these are the Fluency Plus stent graft and the Covera stent graft which we see here. So this is again what happened at SGPG. This I just put because this happened at the time and there was a severe problem where the patient we had to redo an access. So this middle-aged gentleman left RCA fistula, not giving adequate force. There was a juxtaspasmodic stenosis, and he underwent angioplasty of the JS. And after some time, he started slowly developing swelling at the site of the anastomosis, which we kept on observing. We thought it's going to come down by itself. And then after 1 week, 2 weeks, we realized that swelling has become quite big. So we thought we'll do a new fistula, proximalize it, and then probably by diverting the flow proximally, the aneurysm may come down. So, but it did not dissolve, and we had to excise it surgically. So this was the image. This was the proximal fistula which we had done. So this is not the first image. So this is the initial fistula. Scar here, and then we see that there is a pseudoaneurysm happening at the anastomosis, and this is following the angioplasty, and we proximalize this, we create a new fistula here, but then the pseudoaneurysm did not subside, and then we had to excise this as a pseudoaneurysm. We have taken clamps here. This is the proximal radial artery. We have put a clamp. This is the distal radial artery. We excise the pseudoaneurysm. We have surgically corrected it, and I think probably he's doing well with this fistula, proximal fistula. So next troubleshooting is that troubleshooting, that is thrombosis of a non-thrombosed vein. This also we can frequently see when there is extravasation of the vein, or just by passing a wire across, we see that the flow in the fistula has currently stopped because the stenosis is so severe that the wire itself has obstructed the flow. So this is caused by endothelial injury because of balloon inflation, and temporary stasis of flow caused by this balloon inflation in a non-thrombosed vein can get thrombosed. So what to do? We have to limit our inflation time. Sometime as low as 10 to 15 seconds only. Once we have released the wasting, I just if I feel that the stenosis is so severe, I just deflate the balloon and come out. Maybe if there is a further recoil or we feel further stenosis, we can inflate again with the same balloon, or we can upsize the balloon. So what I feel is that with the retrograde approach, the incidence of these kind of thrombosis which happening in a non-thrombosed vein is much more as because the sheath is also sitting in that vein, and it's my personal feeling. It's not. It may not be true with others. In an antegrade approach, it doesn't happen because there is nothing obstructing the vein. Especially in a thrombosed fistula, the thrombus can get stuck below your sheath and it may cause a problem. So this is a case where there's a breakage of AV fistula. So we have cannulated the outflow cephalic vein here. So this was the initial lesion. So there is a long segment lesion. This one immature fistula. So there was a long segment lesion here in the mid arm somewhere. So I cannulated the outflow cephalic vein in the distal forearm. Distal arm. So once we have done that, we have passed the wire, and once the wire is passed, we see that there is no flow going across. And now initially the artery was not seen here. We now, after the cannulation, we see that after the wire is crossed, we see the juxtanosmotic segment, the anastomosis, and the artery also, because the flow in the fistula is gone because of this wire which is occluding the vein because it was so severe stenosis. So what we did, we inflated a 5 mm, 6 mm balloon across the stenotic segment. I didn't take a 7 mm balloon because it was an immature fistula. I didn't want to risk it. So after the balloon inflation, the flow in the AVF was completely lost. I realized that the thrill is gone now. So I had to act. So what I did was that I had to take another axis. That another axis was this radial axis, transradial axis. So I put a sheath in the radial artery. So now I take an angiogram through the radial artery, this one sheath. I see that there is no flow across the fistula. The artery is only opacified. We can see the anastomosis. We don't see the vein anymore. And this is the previous wire which is there from this sheath, which is there in the outflow vein. So what I do is that I remove this. I cross the wire from this radial artery sheath and then cross the anastomosis across the thrombosed segment. Remove this particular sheath which is there sitting in the outflow vein. Remove the wire which is there. Remove the sheath and the wire from the previous sheath. So after this, gently macerate the lesion, thrombus, and then we see that the flow is re-established in the fistula. We see the anastomosis. We don't anymore see the artery here, and we see the anastomosis in the fistula. So when such things happen, we should not panic, and we should be aware as to how to tackle it. And next, coming to the last but one complication, that is arterial embolization. This also we can commonly see in thrombectomy procedures where especially in the brachiocephalic fistula, where the thrombus load can be very high. And we see that the thrombus may dislodge and go into the distal brachial artery or even into the radial artery. So this can quite sometimes be a problem. So sometimes they may not cause any problem. So on table, if the patient develops limb coldness, numbness, cyanosis, loss of pulse, then it is symptomatic. And what are the treatment modalities for this? It can be percutaneous, it can be mechanical, pharmacological, or surgical embolectomy. So usually what has to be done is that when we do balloon maceration thrombectomy, if at all we are using, sometimes especially in the brachiocephalic fistula, sometimes the thrombus can be long segment, and we may need to put two sheaths in the vein, one antegrade and one retrograde. So whenever we are macerating, it is better to push the thrombus rather than pulling it back. Sometimes it can be problematic that we are not able to push the thrombus because the thrombus doesn't allow us to push the balloon. So in that case, we sometimes tend to pull it so that it just moves ahead. The problem in this case is that if it pulls and if you pull it more, sometimes it can just go below the sheath, below the antegrade sheath, which is there in the juxtanosmotic segment, and then get caught below the sheath there and again obstruct the anastomosis or the juxtanosmotic segment. And then that, if you try to move it around with this retrograde sheath which is there above, then you may land in pushing the thrombus into the distal brachial artery. So we should be very careful while doing this procedure. Of course, a hybrid procedure where we can do a surgical procedure to remove the thrombus burden and do an endovascular procedure later to clear the thrombus, or by doing a pharmacological percutaneous thrombolysis by injecting the thrombus at the site of maximum thrombus. All these will help. But if we are not doing that and we are directly doing an endovascular procedure, in that case, this risk can still be there. So, what are all these techniques? So, balloon catheter embolectomy is that we need to pass a wire across into distal brachial artery and into the radial artery where the thrombus is there. Then take a balloon. We can use the same balloon, that is the 4 mm balloon or something, which we have used our normal angioplasty balloon, or we can take a Fogarty's balloon and then pull the clot back and then document that there is no persisting thrombus there. Other thing that we can do is a catheter thrombus aspiration, where we need to put a wire into the distal brachial or the distal radial artery, reach there and take the wire out, put a catheter, and then take the wire out and then give a strong suction on the catheter and then aspirate the clot. Other thing that can be done is to back bleeding. So here, in these two previous techniques, that is balloon catheter embolectomy and the catheter thromboaspiration, what is advantage of these two is that even the fistula, we are not able to solve. Let's assume that we are not able to salvage this thrombosed AV fistula. Even in that case, these two techniques can be used to pull the thrombus out from the distal brachial artery, because we are pulling the thrombus out, or we are aspirating it out. Whereas in back bleeding, we need to have a presence of a functioning fistula, because if the fistula is not functioning, we cannot use this technique. This technique is nothing. We need to occlude the brachial artery, that is the proximal brachial artery, the proximal to the anastomosis with an balloon, and then ask the patient to do vigorous hand exercise. So there will be retrograde flow in the from the muscles into the from the side branches of the artery into the main artery. And then this will push the thrombus back up to the anastomosis. And once we need to ensure that the thrombus has reached up to the anastomosis by doing ultrasound or something. And then once it has reached the thrombus, once it reaches anastomosis, then now deflate this balloon from the proximal radial artery. So that will push the thrombus into the fistula, and then the thrombus may just wash out. So last troubleshooting is the arterial or venous spasm. So it is quite common to have this during the procedure, where the artery and the vein can get go into spasm. One needs to differentiate between the spasm and the pathological stenosis, because we should not be inflating balloon across the spasm and injuring the normal vein. This is what I feel, because there is no end to inflating a balloon, because we inflate a balloon to the normal part, but then the further downstream part will become going to spasm, and we inflate there again, something else will happen. So we need to understand beforehand as to what is the lesion, what is the spasm. So it will help to initial angiogram. We should need to, because sometimes what happens, once we inflated balloon at the stenosis, we see that there is another stenosis there somewhere downstream. So initial angiogram we should have in a picture, or put it in the screen across, to see which was the lesion, which is not the lesion. So that will help to differentiate us from the spasm and the pathological lesion. So spasm can happen because of intimal injury from hardware like balloon and catheters, and especially in immature vein, it is quite common for the spasm to happen. So due to venous or arterial spasm, the flow in the AVS might tend to reduce, and the thrill may reduce or disappear also on the table, and the fistula can become hyperpulsed. So what I usually do is that we use saline and massage technique, where we push some saline into it. We give a massage, external massage on the limb. So that will help to actually relieve the spasm. And even if it doesn't work, then we can give NTG boluses 100 microgram plus minus diltiazem 3 milligrams can be given. Especially arterial spasms don't relieve with these massage or saline flushes. So for arterial lesions, we need to give NTG, or you can wait for some time. Sometimes if the hardware comes out, sometimes even the wire can cause spasm. So if you feel that you have treated the lesion, we can take the wire out rather than keeping a wire there, or not panic and not inflate a balloon somewhere else or something like that, especially in the radial artery or something. We just leave it for some time. The spasm will relieve by itself, or give NTG and diltiazem. So I will skip this last topic, because this I had contrast reactions. So I just skip this because I think I've taken quite a lot of time. So finally, coming to the conclusion. So troubles and complications are an integral part of any interventional procedure. So have multiple plans in mind before starting the procedure. Have adequate hardware in your inventory, like sheets of various sizes, different types and lengths of guide wires, and different types of balloons. So always before starting the procedure, ensure that all those inventory is there in your with you, either a new one or Oxford one. So it is not that everything should be, you need to open everything. You think what you want to open, because working in a corporate hospital, we should always think what we want to open, what we should not open. So as much as reduce what you can use, don't use open multiple hardwares not knowing what to do. Uh, and don't panic. Most importantly, don't panic. Work with a clear mind. With time, things will improve. You don't need to either wire extravasate or if there hematoma. No need to worry. Patient may feel some pain. You can give sedation. We can give fentanyl, 50 micrograms or 100 micrograms, or we can give some sedation like midazolam. We can give up to 10 milligrams, but usually I don't prefer giving 10 milligrams like that. We can give 3 or 4 milligrams of midazolam. We can sedate the patient and we can soothe the patient so that they don't feel the pain of the hematoma or the inflation of the balloon. So that will give us time to understand what is happening, and with time things will slightly change, and we can need not suddenly panic. And we need to understand, think in our, once our mind is clear, we can think as to what we can do next. We can use smaller wires, we can use different axes, we can change the sheath, we can change the wire. So all these things can be done, and better to keep interventional radiologist and vascular surgeon in the loop. So my sincere thanks to my teachers, Dr. Narayan Prasad sir and Manas Patel sir. Without them, I will not be able to do anything. And also thanks to Bala sir and Ram Mohan Bhatt sir for this opportunity, and my team at Manipal Hospital, headed by Sudarshan Balan sir and Vishwanath sir and all the other units. And my thanks to all the other intervention nephrologists, Girish sir, Sabas sir, Venkatesh sir, Hardik sir, Vineet sir, Dr. Manish and Dr. Santosh, and also my sincere thanks to all the nursing officers with whom I trained at SCPJ and also at Manipal. Thank you.
Thank you. Thank you. I think it was a wonderful talk. I promise I'll post the recording by tomorrow or day after, because for beginners, I think it will take some time to grasp, because he had to go very fast, because he had to finish most of the procedures. Because he was telling me that when he tried recording this, it took more than 1.5 hours. I mean, the recording lasted more than 1.5 hours. So he had to rush. But I think he has given very valuable tips, which will be of great use if you keep this recording in store. And any other thing to be added by other faculty here? This length of the wire, sometimes it is better to choose the longer wire, especially if you are, meddling the subclavian vein or something, because there was an instance when there was a very tight lesion in the brachiocephalic vein on the left side, and with great crossed the lesion, and the wire went into the SVC and into the atrium, and the balloon, what happened? It got stuck. So I had to. I mean, the balloon got stuck to the wire because of some blood clots in the wire, or it was Oxford balloon, and it wouldn't come out of the wire. So I pulled both the wire and the balloon together, but the length of the wire was not just enough to reach the sheath here. It slipped out of it came out of the tight stenosis, through which I had great difficulty crossing. So that day I had to come out without finishing the procedure. So if you're going to have only problems only in the forearm or arm, that's fine. But otherwise, I think the 260 wire, the longer wire, when if you have to exchange the catheter or balloon, you may need. And also, when threading the balloon over the wire, you keep cleaning the wire with wet gauze, because any small clots which may not be obvious to the eye, the balloon wouldn't go. It won't glide over the wire easily. So keep it in mind, and keep on. I mean, this trained technician, they keep dripping saline over the wire frequently without your knowledge also, and they keep going.
This usually happens if you use an Oxford wire, sir. Not the balloon, but the balloon we can't use a new balloon every time. But because I've seen that here they use Oxford wires, I strictly tell them not to give me Oxford wires because they actually the Oxford balloons, the Armada and all, they don't prepare it properly, they don't reprofile it properly, and then the lumen of that catheter would have got kinked at places, and an Oxford wire will you will be having very difficulty in navigating it over the wire itself outside the sheath. And in such cases, if it gets stuck inside, then we may have to pull the wire out only completely, sir.
Yes.
So the Oxford wires, I usually don't encourage because they initially they give Oxford wires only. The hydrophilic coating of that wire would have got damaged.
Yes, yes. Then another thing, I remember when talking about hardware requirement, I always have a guiding catheter besides diagnostic catheter with me because now and then when the lesion is too tight, and you also showed where you had to wear and a small balloon to cross the lesion. So if you have only a diagnostic catheter, it won't suffice. You can't put in a balloon PTCA, I mean cardiac balloon into it. So when Manish, I think from Vellore, he was surprised. Why you need a guiding catheter at all, sir? I have never used guiding catheter. Diagnostic catheter and the wires and balloons. That's all.
Yes, sir.
Good you gave that point. The instance where you had to use a PTCA wire and a NC cardiac balloon. So even juxtaosmotic stenosis, sometimes they're very tight. You may have to resort to smaller wire and cardiac balloons, pre-dilatation before putting in even the glide wire.
Yes, sir.
Shabas, Manas, I think nothing much to add. It was a very exhaustive talk.
This one, Hemanth. When you're constructing the radiocephalic fistula, so my suggestion is you can do intervention through the distal radial approach. That is, you can cannulate the radial artery in the first interdistal space. In fact, I'm doing the procedure mostly for that one. So you can construct the fistula even near the wrist. The advantage is your venous segment is spared. Secondly, the dorsal cephalic vein that is also spared. So if your fistula cannot be salvaged, you can just mobilize this dorsal cephalic vein and anastomose with the radial artery. So that will save the troubles. And plus, even if your palmar circulation has got some problem and you're intervening through the distal radial approach, that is, if you can see my hand from here,
Yes.
that is the first interdigital space, there will not be any problem. So, and if you cannulate it and you practice it, you'll find it is even simpler than doing the snap box one. So that you can do one thing. Uh, and another thing that I would like to highlight is whenever you are doing a transradial approach, and if you have taken out the wire, took an angiogram, again now you are trying to inflate the balloon. So always please confirm that it's in the vein only because the artery and the vein both are in anteroposterior. So I have learned it very hard with that pass the wire afterwards and inflated the balloon, and in fact the balloon is the radial artery instead of being the vein. So always whenever you have taken out the wire, confirm it that's in the cephalic vein only instead of doing angioplasty without confirming it. And the
Yes, sir.
third thing is when you're treating a tight lesion, one important thing is when you're deflating the balloon, before deflating the balloon, just press the inflow so that the flow doesn't start when the balloon is semi deflated or semi whatever you want to say. Because this is the time when the pressure is the maximum in the that particular dilated segment. So if you're pressing the inflow till the balloon deflates completely, approximately, then if you release the pressure, now the flow will go with minimum increase in pressure there. So the chance of extravasation will be much lesser. Especially when it's an immature fistula, you have treated very tight lesion, something like cephalic artery, juxtaanasmotic part, I mean the intercannulation zone. So press the juxtaanasmotic part till the balloon completely deflates. So that will reduce the pressure in the venous segment, and the possibility of extravasation will be much lesser.
Yes, sir. I follow this. I usually occlude the flow in the fistula when I'm inflating the balloon in the veins.
Regarding one part I would like to add is in the radiocephalic fistula, when you have taken a retrograde approach, at times it will be difficult to pass your Mustang balloon through that angle. So in that case, you might have to change the wire to either PTCA wire or you change to V18 wire and then do the inflation with Sterling balloon or PTCA balloon. Then only you will be able to pass it. Many a times, what is when you push the wire, it will go towards the wrist and it will not go into the proximal radial artery. So sometimes you have to use the smaller profile balloon. So that those are the only points which I wanted to add.
Okay.
Yeah, but it was definitely a good presentation, Hemanth. Really a good review.
There was a message here, sir, from someone. What is the load of the thrombus that we need to any clinical or USG method to assess thrombus load, and which thrombus load shall cutoff shall lead to embolization or something like that. So usually the embolization, the thrombus load can be measured by doing a cross-sectional diameter. The volume of the thrombus can be measured. It is usually said that the volume of thrombus should not be more than 50% of the pulmonary circulation to try macerating it. The pulmonary circulation volume is around 700 to 800 cc is what is said. So it should be 50% of that 50%, that is approximately 400, 200. So the thrombus load should not be more than 200 to do a direct manual maceration. And if that in case, but it's quite difficult to calculate that amount. But
I
what?
don't think Hemanth anyone will be taking that risk of pushing, say, about 200 to 300 mils of clot into the pulmonary circulation. So, thumb rule is you will not do the just this pharmacomechanical thrombolysis if it's a mega fistula, especially brachycephalic fistula, which have got thrombus because cephalic nerve stenosis. In those cases, it's better not to do just mechanical thrombectomy. I mean, surgically you can remove it, but you should not be attempting mechanical thrombolysis. There, the possibility of clot going to the pulmonary circulation is too much.
Yes.
So, yeah.
Sir, I have one doubt. Actually, normally for the pharmacomechanical thrombolysis, routinely we use alteplase, or is there any usage of streptokinase because considerably cheaper and if it's the first thrombus load, do you even use streptokinase in such situations, sir?
Deepak, this is probably Dr. Arun he is doing with streptokinase, but to me, I haven't done it once I have passed my MD. I had used it during MD for thrombolysis of acute MI. Afterwards, we have been using either alteplase or retiplase or urokinase at the least. Urokinase in the between, it was unavailable, but I'm unsure if it's available now. That's quite cheaper. So you can go for urokinase if it's available.
Okay.
With streptokinase, no, we don't use it anymore.
Okay, sir.
Okay, I think we had a very fruitful and a long session. And I thank all the speakers, the senior members who shared all their experiences, and all the participants. I think we'll close now.